If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further, the weekly roll-up. This week, Marcus is off. He is relaxing, recuperating. I'm not sure where he is, but we have Dr. Kam Matthews here. Kam, thanks for joining. Appreciate you doing this.
Hey, Vic, thanks for inviting me back. I know I didn't make it that last time.
I wanted to have you as a guest host for a while, and we had scheduling issues and things previously, but you're here now. Excited about it.
Yes, I'm excited. I enjoy this conversation every week. I really do. So.
Yeah, you're a longtime listener, but we have not been able to have you on and get your wisdom for everyone yet. So I'm excited for this week. So maybe give the audience a little of your background.
Yeah,
you actually are qualified. You're an MD, but you've done lots of things. So and you have some new stuff upcoming. I don't know how much we can share, but maybe talk about where you've been the last few years.
Sure. So again, Kam Matthews, I am a family physician by training, and the last 4 years I served as Chief Health Officer with CityBiz Health. Of course, probably most of your listeners are familiar with it, but we are a value-based advanced primary care practice focused on Medicaid and dual eligible populations across 10 markets. It was an unbelievable experience for me. My first time with a startup, my first time working in the value-based space. Prior to CityBiz, I was actually with the Veterans Health Administration for several years, helping lead them through multiple different transformations, as well as the COVID pandemic. So that was an interesting transition, you could say, to say the least, from government to startup. But I am looking forward to my next transition. Starting in January of 26, I'll be working with another startup as Chief Health Officer as well, focused on a kind of a different perspective of primary care, leaning more into the public health space, I would argue. But I'm really excited. I'm glad that my career has been able to focus on underserved populations. So I'm definitely continuing with that with my new opportunity.
Yeah, excellent. So, I mean, I want to weave it in through the stories this week because we have there's a lot of issues around Medicaid today and public health broadly. I think we're all, at least from my point of view, we're struggling with what does public health even mean post-pandemic, and how should we take care of, as a society, how do we take care of our community, all of our people?
And where does the responsibility lie? I think that's the bigger question right now, especially coming out of this administration. There's a lot of focus, obviously, on self-empowerment, and I think from a public health standpoint, that has been at a little bit of a juxtaposition of where we've tended to lean as a country. So
I think that's right. So and I'm all in favor of self-empowerment, and in addition to that, we as a society have to pay for services so that people can be empowered to take care of themselves. So there's a balance there where it's not fair to say to the population, you have to take care of yourself, but not give them any resources to do that.
Exactly. Yeah. It's really about allowing for there to be some empowerment so that people can actually take advantage of the new science, the new technology, if it's available in someone's network, but they don't have the ability to actually access it. That's a completely different, obviously, sense of ownership of how that person can take advantage.
It's not realistic for them to be, they're not empowered. If they don't have the resources.
No, exactly.
Okay, well, let's jump in. We have a lot of stories to cover. Excited to dig into it. We finally got the September jobs report. Of course, we are talking on November 20th. And so it's quite, with the government shutdown and everything, quite outdated. But it was a surprise to the upside. So 119,000 jobs, people were hired in September. So that was slightly good. But the unemployment rate also ticked up, and then they revised August down. And so for people that are watching here, the August number was just minusculely negative. It looks pretty flat on the chart here, but it's been anemic job growth, for the summer. September was better, of course, than a slightly negative. I don't know. I know you're not an economist. It's pretty outdated. Any feedback from this? It's positive, I guess. It's sort of lukewarm.
Yeah. I mean, for the unemployment rate to be going up as well, that means jobs are being created where people aren't able to take advantage of it. I'm assuming. So I'm
Well, yeah,
wondering.
1,000 new jobs were created,
Yep.
but I think maybe slightly more than that number of people lost their jobs, or
hmm
so somehow the unemployment rate
Yeah.
ticked up slightly to 4.4%.
Exactly.
It's been,
I can't
fairly
wait.
stuck at that 4%.
Exactly. I can't wait to see what sectors were
Yeah, I
impacted
mean, healthcare has
by all
been,
of these numbers. Exactly.
pretty strong,
hmm
because we need a lot of people. We're in a shortage in healthcare, really. So,
hmm
so I don't know. The economy is still. Marcus and I talk all the time about the K-shaped economy.
Yep.
If you have a lot of wealth in financial assets, in stock market and real estate, you're doing well. Maybe better than well right now.
Yeah.
But if you don't have significant net worth and you're living, either it's paycheck to paycheck or you have a 401k, but it's not that significant, it's hard out there. It's hard to keep up with the cost of living increases. So I guess it's positive the government is issuing reports again, but they didn't update anything in October. They had talked about that as recently as Tuesday,
hmm
and then they yesterday decided, no, we're just gonna do September, so no
Yeah.
October information. So with that, let's move into the VC raises. A company called WellBeam raised $10 million Series A to transform interoperability care coordination from the acute inpatient hospitals to the post-acute setting. This is
hmm
a space I've done a lot of work in. It's a huge problem. What do you think of this deal?
Yeah. I mean, I think it's exciting. I mean, to me though, there's extreme sensitivity to success of this based on who's actually adopting their platform, right? So in any given
Yeah.
geography, there could be a number of post-acute providers, and if it's only really being adopted by one or two of them, along with the major health system in the area, that could lead to some real inequities of coordination and
Yes.
interoperability, right?
Yeah.
So I was looking on their website to see like if they're even, describing any of the big national post-acute players or any, they're not listing any, but it's exciting. I agree with you. It's a huge area of concern. There's very little communication back and forth, and that's why you see the readmissions. That's why there's unfortunately increased unplanned post-acute care because they're not able to communicate and really plan ahead. But if WellBeam doesn't have broad kind of adoption, then
Yeah. I mean, it's fine to say break down the silos of data, but if you are creating a new, pretty small, you know, connection point, it's
Mhm.
sort of another silo,
Yeah,
kind of. I mean, they
yeah,
don't position it like that in the press release, of course, but
yeah, yeah. I mean, it
I'm
required some
biased as
significant,
well. Yeah,
yeah, it
I'm
requires
biased
some
because I invested
significant
in a
vertical integration for it to really work and reach
right.
the outcomes they were describing. So,
Yeah, yeah. I was gonna say I'm biased because I invested in sort of a Slack or Teams like competitor for all of care
hmm
across providers,
hmm
which is designed to not be any one silo, but sort of cut across everything in the messaging layer. But I think an all of the above solution for this issue is probably good. So
hmm
happy to see them at least working on it. And then FamilyWell Health raised $8 million, and this is a women's mental health provider,
yeah,
and they have been sort of up in New England, Massachusetts, New Hampshire, and this is going to allow them to go nationwide. A
hmm
lot of attention in women's health
hmm
recently, but there's a lot needed. There's a lot
yeah.
of demand. What are your thoughts about FamilyWell?
Yeah, I was excited about this. The founder is a neonatologist who had some personal experience around postpartum depression. She shared, and this is a critical space where we need this level of integration. Again, as the operator, my mind immediately goes to where is this being implemented? Being that the majority of postpartum care isn't postpartum depression isn't necessarily diagnosed in the OB/GYN office, it's actually in the pediatrician office. So where is the integration actually occurring? How are we making sure we're thinking even beyond just the immediate spaces where FamilyWell and the OB/GYN services are being provided, but more holistically, primary care practices, pediatrics offices. So I love this. It's the right direction, but I think none of these solutions are meant to be a panacea, but it may still leave some gaps depending on who's actually receiving the services in these clinics.
Okay, and then Thrivory raises $3.5 million, and in addition, a credit funding facility. Thrivory is an interesting company that it's in the revenue cycle management space, I'd say, where they sort of are submitting claims, but they have this option to get paid immediately for physicians where they take on the risk of collection, which is why they needed a credit facility. What did you think of this? I'm torn. It's interesting, but there's a spread there where they're going to pay the docs less if they are taking the risk, which, obviously the doc can choose, but I don't know. I'm torn about this one.
Yeah, same exact feeling there. I think maybe for some of our smaller hospitals, safety net hospitals that could benefit from getting paid today just because their cash flow is so strapped, this could unfortunately not necessarily be as positive for them because of that additional piece that Thrivory is going to have to maintain. Yeah. I think the larger hospitals that could really use this are probably a bit more integrated with their payers in the first place. So would they even need this? I'm not sure.
Okay, and then Function Health, which is of course already a unicorn, very large. I think of them in the longevity space for wealthy folks to get a full evaluation, huge kind of preemptive screening. They raised almost $300 million, $298 million. A huge round in a company that already, has a lot of traction. What's your thought about Function? Maybe broadly, not necessarily this round, but just
I'm a bit weary around these, just kind of, I like the word you use, preemptive kind of preventive care. I mean, I'm all, as a primary care doc, in favor of this. I think it obviously, they Function, as well as any others that are in this space, need to make sure, again, that concept of integration back with an individual patient's provider, like how is this going to be managed? What sort of support is there really going to be for the patients that are taking advantage of this lab work? I'd be a bit nervous. There's also, some waxing and waning evidence around, the need to do this amount of screening and whether the cost benefit is really there. I think this will
well, and the cost benefit I would take the cost benefit in even a broader sense than just financially. Like there is a financial cost. Clearly, these are wealthy people typically that are paying out of pocket.
Exactly.
But there's also an emotional, physical sort of cost of, you find something that needs to then be looked into, and so then you have to do additional labs, maybe take a biopsy, and it is more than just financial cost. There's the stress of like feeling that, maybe I have cancer somewhere and then you don't have it. So there's a lot of different costs that have to be balanced against the benefit. Obviously, there's a huge benefit if you catch something that's treatable, but I think it's up in the air as far as, is the overall cost worth the overall benefit in this case? I haven't done one of these. It's not a financial decision. I'm just not sure that I want all of this information.
I haven't done the lab work. I've done the full body MRI. I was able to take advantage of, and Function is offering that sort of imaging as well too. I've done that, and the data that came forward was definitely something I personally needed to parse through because they made recommendation for a significant amount of follow-up care and little pieces, and I was able to personally reevaluate, look at that data. The average person is not going to have that capability. And will they have the ongoing support to help them through that as opposed to just the initial, data review that the ordering company might be making? I'm not sure. I'd be nervous.
Many people won't. I mean, you have the medical knowledge and experience to parse through that.
Exactly.
There's very few people that can do that. Okay, moving into policy. California's campaign to introduce a wealth tax. It would only tax billionaires, So if you have a wealth, not earnings, accumulated wealth, both liquid and importantly illiquid, artwork, intellectual property rights, real estate, that exceeds a billion, 5% would be a one-time tax. And interestingly, in order to pay for everything in California, but healthcare being top of the list. What are your thoughts about this? Now it's just a proposal. It'll be voted on next year. I
Yeah.
think that's what they're trying to do, is get it on the ballot.
Yeah, I don't know. I don't call myself the Democratic Socialist, but I think it's starting to come out when I read stuff like this about what's
Mhm.
happening around the country, about kind of the redistribution of wealth. I would say is necessary in times where we're really having questions around healthcare services and other social needs and the like. I think this is an exciting conversation to be had. I think it's worth acknowledging broader concepts of wealth beyond just income, because we know that there's a lot of kind of shepherding of person's wealth into these kind of protected spaces, and I think there needs to be some redistribution so that everyone can at least have the baseline of healthcare, of food, of housing, and that's what the state would presumably be redistributing to. So,
Yeah, yeah.
I look
There's
forward to the
no
conversation.
question on the intent. I think
Hmm.
I agree completely that we have to find a way to pay for healthcare and other basic services in our community that the government needs to provide. I mean, I wrote an entire book trying to wrestle with this because I think it's going to be the issue in the next 10 years in our country. I mean, we see it with the New York mayoral race.
Hmm.
So you're getting both coasts now. New York certainly is moving in that direction. California is as well. It almost doesn't matter the result of this particular vote. We have this trend going
Hmm.
on.
Yeah.
Um, I think it's going to be a huge issue between generations, basically. So like the boomer generation, that's how I think about this. The boomer generation has a lot of wealth and they will stop working over the next, many have already stopped working, but over the next 10 years they'll age out of working. And the estate tax, has been the way that our country has sort of corrected for this, where when you passed away, it's a wealth tax. The
Yeah.
estate tax is a wealth tax.
Correct.
Um, but there's been so much effort at tax sheltering around that it's not that effective anymore at actually
Right.
putting money into the system and sort of correcting for this generational issue.
Mhm.
Um, so in my book, I kind of started with a discussion of values. Like
Right.
and now this is not this story. This is my personal opinion, which I'll get off my soapbox in a minute. But I sort of think that health care should be a human right. Like
Yeah.
you have a right to health care, and
Mhm.
then we quickly get to, well, what are the limits to that?
Mhm.
Um, and so my second value was that it should be allocated equally across generations. It's not fair
There we go.
for the boomers to take more than their share of the available resources and then take that away from the millennials,
Yeah.
basically. And the millennials, I think, are driving this trend. I mean, I think they certainly drove the New York mayoral election,
Mhm.
and they're a huge, powerful generation as far as voting bloc.
Yeah.
And we need to resolve this issue.
Yeah.
And it's going to be you can read my book for more. There's going to be 10 years, maybe 20 years of discussions around what is the right way to kind of divvy up the pie, but it's not, the status quo is not going to work. And so
No.
I think we have to solve this. The thing I worry about is the slippery slope. Like no one is going to cry for a billionaire having to pay 5% one time. I'm
Mm-mm.
certainly not going to. But the worry I have is that someone with $1 billion in net worth has lots of options of where they kind of call themselves as primary located, even if they are in California for, lots of things that California is great at. I mean, incredible beaches, great opportunities there. But the billionaires may decide to put their residents somewhere else. I mean, in Tennessee, for instance, there's no state income tax. A lot of people already have moved to Tennessee and Texas and Florida and, the typical tax havens. And so I just don't know if it will have the effect that, is intended. But we'll see. I think it's certainly going to be very popular. It would likely pass if it gets on the ballot. So I don't know. It's going to be something just to monitor over time.
And maybe the millennial population in states like Tennessee will start to reconsider this as well, too. I mean, if the trend is really shifting, I agree with you. As you say, generationally, Tennessee won't be exempt from it as well, too. It's a worthy conversation to have, as the billionaires will be looking for places for more shelters that maybe there's a larger trend that needs to occur more broadly.
Yeah. I mean, I came to, in my book, that we should try to figure out a way that about 10% of all healthcare spending should be spent in public health, primary care, sort of taking care of people in ways that are not cutting edge, don't need to be high margin, but we have to deliver these services. I'm calling them healthcare utilities. But we have to figure out a way to take a significant amount of the $5 trillion we spend in healthcare. I picked 10% just because it's double the 5% we pay for primary care now.
Yeah. And there's
I'm not sure double is the right amount, but it needs to be more than we spend now on primary care.
Exactly. There's some state proposals they're pushing for 15%. Yeah, I agree with you.
Yeah, it might be 15%. So anyway, that's going on in California. That will continue. And then this was, I thought, a really good article from the New York Times, really focusing on the Medicaid cuts coming next year that have been talked about, a lot. We've talked about it here on the show. There's going to be, basically the supplemental payments, the tax structure that has been used for 30 years by red states, blue states, every state to help fund Medicaid is not going to be able to be growing at all, and it might face cuts over time. The Republicans, after feedback, people being upset about that, offered a $50 billion fund to help rural communities, rural hospitals, which I'm in favor of. But of course, there's a lot of Medicaid recipients. City Block, where you worked for 4 years, is focused, I think, primarily in urban areas, and there's a lot of need in urban areas that, just by the title of it, the rural fund won't help. I don't know. This was a good article, but kind of a sad article. So, I mean, what are your thoughts? You've lived this for a long time. Yeah. So, what are your thoughts about this?
Yeah, even before City Block, I've always worked in urban underserved areas, and I think the safety net hospitals are clearly going to be impacted regardless of rural versus urban. And I think there's a bit of a political slant in creating the Rural Transformation Fund. I think there's a bit of an overrepresentation there of how solely or even to the exclusion of urban hospitals that rural hospitals will be impacted. And this article just speaks to the larger impact. It says 85% of the hospitals they surveyed were in urban areas. So yeah,
I mean, that's where a lot of the people are. So I mean, I don't think that's controversial. Most of the population by numbers lives in urban areas. I mean, I think that's factual. So the Times did a good job sort of digging into it. The more I learn about it, the more I am concerned about our Medicaid population. But I don't know. It's an ongoing worry. And then to sort of finish the policy, a jury awarded Masimo $634 million for them violating Apple. Apple is in violation of Masimo's patent around Pulse. I think it's a pulse ox patent. And I think they clearly are. And the jury awarded this. Apple's they're going to appeal, but I think justice was served here. I don't know if 600 is the right number or not, but they clearly didn't do the right thing against Masimo. So
this tied along with the conversation over the past couple of years around pulse ox and pulse oximetry and how there's a bit of concern around the ability of pulse oxes. I think you guys might have talked about this on the show, the ability of pulse ox to have accuracy with darker skin. And so what I'd be nervous about, if there isn't the additional conversation of how these sort of wearables are then going to be able to address the inequities that we see in this type of monitoring. I'd be nervous, Apple continuing to fight this and the like, are we holding Apple even more accountable for the accuracy of this? And even Masimo, it can't get lost that this technology is still not exactly as accurate as we need it to be.
Yeah, no question. And we need to do more studies on that, I think, to understand where does it fall down, and more importantly, how can we adjust the technology so that it can serve the whole population, no matter what your skin color. So,
but I'm glad Apple's being held accountable. I'll say that much. Now let's continue with that. I guess I'm arguing.
Right. Yeah. In Fierce Healthcare, we're switching to payers here. Humana and Epic collaborate to automate the insurer verification process at patient check-in. And so Humana is working with Epic. If you are a Humana customer and you go to an Epic facility, which is, probably 70% of the hospitals, you no longer will have to do that clipboard and show your insurance card. And that's great for that population. It's sort of a subset of the overall population. So I don't know. What are your thoughts about this? I thought it's great for that population. I'd like to see it more broadly.
That's exactly what I thought. This is great. This is necessary. It's a huge dissatisfier for patients at check-in. But how is this going to fare for broader populations, perhaps where they have multiple coverages? I'm thinking of the veteran population, the Medicaid populations, and even the traditional Medicare with supplemental coverage and everything. It's nice and neatly packaged for MA, which of course is where they needed to start. But what's this going to look like the next step?
Right. And if you are, here in Nashville, Vanderbilt, they're on Epic, but is the medical kind of administrators there at check-in, are they going to change their entire workflow because the Humana MA patients don't need to? Maybe they will, but there's a lot of other payers. And so the person, it's a human at the check-in, he or she's going to have to figure out, okay, I give the clipboard to 8 out of 10 people, but these 2 I don't. That seems like it's putting a burden on our workers where they already are kind of busy. I don't know. It's a good step, but I don't know how much it's going to be impactful. Okay, and then medical groups are pushing Anthem to kind of come back to their out-of-network policy. So in about a month, Anthem's new policy of penalizing the patients when they get an anesthesiologist that is not in network with Anthem, that's going to be really difficult. And the hospitals and other medical groups are pushing Anthem to rethink this, but so far they haven't. This is an ongoing issue of in-network, out-of-network. What are your thoughts about this? Do you have experience in this space?
I have to side with the patient on this and the protections that we need from no surprises, right? This is wholly a difficult piece that the patient has absolutely no control of. And the controlling party is the hospital. They are the ones that make the referral. They are the ones that can in otherwise really have an understanding from a network standpoint of how to place these orders and make these referrals. I think it has to sit on the hospitals. And it's going to be difficult for them, but the burden should not be on the patient.
It can't be on the patient. That's not going to work. I think there's a real issue, and we'll have another story later about how the payers are building their provider networks, and they must be sufficient.
Yes.
Right? I don't think it has to include every anesthesiologist, but you have to have appropriate coverage, or you shouldn't be a payer in that geography. But then the health systems need to sort of make referrals, within reason to in-network anesthesiologists. So if I'm getting my hip replaced, I don't get to choose the anesthesiologist. That's what you're saying. I pick the surgeon typically, but then it's opaque to me who the anesthesiologist is. And even if I wanted to choose, the hospital would let me. They don't have that latitude. So yeah, it's a huge issue.
That's exactly it. But I agree with you. The burden also needs to be on the payer from a network standpoint, or else the health systems won't have any ability to control this either.
Yeah. And then Aetna unveiled AI navigation tool. So it's like an AI assistant that helps the Aetna patients understand their coverage and what their financial responsibility would be. What do you think of this? I thought this was a great approach. I mean, again, it's only one population, but in this case, if I have Aetna, I can now use this tool, and it will help bring hopefully more transparency to what is a very confusing, opaque space.
Yeah, I think
And
it's
maybe that people will join Aetna more because they'll opt into it.
I think it's exciting. I can think of a time when I had the call and I just got directed to multiple different offices because they weren't sure whether it's medical benefit or pharmaceutical benefit and all these different things. Like hopefully that one AI is as integrated as possible across the different pieces of the individual patient's contract. I think that would be the piece I'd be nervous about, and how really personally adapted it is, because they say it's full and personalized breakdown of their contract. I was like, I hope that it really does get into the weeds of an individual patient's coverage. And if it does, very exciting. But if not, it could be a big source of just escalation to, someone's just going to keep clicking through to customer service.
Yeah. I mean, I'm going to take the positive take here. I think that Aetna trying to actually help its members understand the benefits that at the end of the day they are buying, or their employer or a government group, someone has paid for them to have. That's a good thing. Now, it needs to work. But the fact that they're working on it, if it is really good, more people will go. And then, that's the American way. Competition will drive every payer to have a tool like this eventually.
Completely agree. Yeah.
Okay. So the last story on the payer side is in the Wall Street Journal, pretty long, almost like investigative piece called Medicaid Insurers Promise Lots of Doctors Good Luck in Seeing One. And they went through many states' Medicaid provider networks and found a pretty shocking, and at least for me, it was shocking and sad. There's a list of lots of docs that are available that take Medicaid patients in the provider kind of network. But when you actually try to book an appointment, it becomes very difficult to do so. So this is your market. So have you experienced this? Is this what do you think of this article?
Every day, Vic. This was my entire residency training and initial sort of experiences in FQHCs, where I really felt my care team and we ended up being just kind of referral coordinators, trying to make our way through these network directories, trying to
because in primary care you refer them, like, you need to go see a orthopedic surgeon, and then they have trouble even finding one.
Yeah, calling through and I'm glad they highlighted psychiatry. That's definitely the most difficult space where we just did not have enough integrated behavioral health capability within our own practice. So I needed to refer out. I mean, it just is unfortunately nothing new. I think when I read this, I loved that the journal went into this depth, but it's absolutely nothing new. It's not something that unfortunately we've seen a lot of change in. Not only are the network directories not updated, but you're also seeing a lot of practices that just aren't taking Medicaid patients. So this is what, unfortunately, primary care, as well as other fields, and all of us that are needing to coordinate care for our patients, we see this every day.
Yeah. I mean, I think that is kind of a recurring theme in my discussions with physicians and hospital administrators and even payers.
Yeah.
There have been kind of chronic systematic issues in the U.S. healthcare system unfortunately, for decades.
Yeah.
And at the same time, I think it is helpful for the Wall Street Journal to dig into this and then publish, a pretty long article, because it reminded me of this, and they did a good job sort of stacking up fact, which is hard to deny. It is not right to say that in all of these areas, the provider networks are sufficient. They're just not sufficient.
Yeah.
And we need to figure out a way to solve for that. Unfortunately, from our early stories, Medicaid is going the wrong direction. It's going to be less reimbursement, not more. So I think this is going the wrong direction. But yeah, it's a hard story, but I think worth reading. We'll have a link in the show notes about it.
I think every state needs to take a policy lens to this exact topic. They talk about South Carolina in the article. I think they need to be digging into what network adequacy actually is. How are they actually holding payers accountable to prove that there's adequacy? This is actually a huge area of my focus when I worked in the VA, because we had to build network adequacy in the network for veterans under the community care program. And the
VA kind of is a great place to learn about it, because you have the full stack. You're the payer, the original payvider is the VA. And was it difficult to find physicians in certain subspecialties or certain areas?
There definitely is. I mean, there's definitely just geographic gaps as well as just volume issues. There may be a single orthopedic surgeon in a rural geography, but they just have a ridiculous wait time. So we had a lot of conversation around how we think about telehealth to actually address some of the network adequacy issues. I think that's one thing that we were really leaning in within VA to assure that we could offer as much services as possible virtually, so that we could even back down some of the volume that where patients are actually physically scheduled. But that takes like an upheaval of everyone's schedules, of everyone's network, and at least in VA, we could drive that. I don't see that being a larger trend for Medicaid, unfortunately, how we actually think about which patients are being seen and which are virtual.
Right. Okay. So then Cigna is launching a new transparency plan called Clarity. So this is a kind of a new approach by Cigna. And again, for the listeners, Cigna has moved out of government-backed healthcare. So they really only do employer-based care. And it seems like an interesting model for that, where an employer now will have an option to choose from, cost sharing options, but then they're sharing it with the employee, but it's fully transparent as far as like what everything costs. What is your thought about this?
Yeah, I mean, we'll see. I think a lot of the cost sharing options, this being only co-payment versus kind of the deductibles and the like, I think different types of patients will feel comfortable with co-payment versus the deductible conversation. I need to see the math. I don't know. I think it's just another shuffling of the deck chairs, to be honest, to try to drive patients to have a bit more accountability.
But I like getting rid of co-insurance. I don't mind. I think people understand the deductible okay. Co-insurance is where patients do not understand, and it drives a ton of bankruptcies. Unfortunately, it's really sad. They just don't. So getting rid of that was the key for me. But
the transparency piece will help with hopefully, those patient populations that are able to actually dig through a lot of the cost involved and everything, and make those decisions with the information being provided. I can't say that would be a positive move for all populations, though.
Yeah. Well, in Cigna's case, because they're really only working with employer-sponsored plans, it could be designed where it could be really positive. You're right. It wouldn't work for every population. Okay. And then a story from Healthcare Dive: Ascension's investing $530 million into Middle Tennessee here, right where we are in Nashville. So, it would be an interesting story no matter where, because $500 million is a lot of investment into one geography. But because it's where I live, it caught my attention as well. Ascension's investing in sort of upgrading their facilities and bringing technology and improving the hardscape, the buildings. It would be good. What are your thoughts about this?
I think my bias is going to come through with every story, but my first question is always going to be, how much of this is going to be invested into primary care, into ambulatory and community-based care? That's where we can actually think about prevention. We can think about, thinking upstream about solutions and the like. If this is just more bed space, which is needed in some geography. So I'm not, you have a much better sense of what's going on there in the middle of the state. But I'm wondering how much of this will be built into more ambulatory services for patients. It talks about
Yes.
decreasing travel time, but if that's only for acute care, then we're still just going to see.
Yeah. I don't know the
the same
answers,
sort
but
of trends.
my observation over many years is that most commonly health systems invest in new surgery centers or a new diagnostic imaging or
Yep.
things that are not necessarily primary care.
Yeah,
So
exactly.
positive, but maybe not. I agree. Maybe not where it's most needed. It probably is
Yeah.
more where the reimbursement is the best.
And
Now, I haven't looked
can't
at their
fault
plan,
them,
but in
right?
general, that's right.
Yeah, can't fault them, but I think we need to right size how we're assuring utilization leans in the future and continuing to build these massive campuses and the like, I would argue is not necessarily.
Right. So Common Spirit released their operations report. So they're a nonprofit, but they come out with their financials every quarter, and they had an operating loss. They're still kind of navigating these, pretty challenging times. Seems like they're holding on okay, but they have challenges in all fronts. What did you think of Common Spirit?
Yeah, they said it was some supply issues, definitely salaries and benefits. I'm wondering, as much as different systems are bringing on AI solutions, like how much of this, especially on the supply side, they could actually look at addressing through, maybe some increased efficiencies with, how they're thinking about supply chain, how they're actually addressing their labor issues.
Mm-hmm. Yeah,
So
I mean it's a
maybe in another
hard
year or so, this could be different. Yeah.
yeah, I think they're making progress. That Common Spirit has a hard sort of footprint and a lot
Mm-hmm.
of challenges in making this turn. And so I applaud them for working on it, but there's a lot to work through. They have a significant, kind of fixed expense with all the buildings and people that they need to deliver the care.
Oh, definitely.
And so they have a lot of challenges, but good that they're still working on it. And then
Yeah.
Providence's operations also came out. They were slightly positive. They made a little money, a little positive
Mm-hmm.
income. So good to see. There may be like a step or two ahead in this transition. It's also it's a smaller system and maybe slightly better markets than Common Spirit, I think, on
Yeah.
average. So
The one statistic that jumped out to me about Providence, 33% decrease in contract labor spend, which meant they're really trying to think more, long term, maybe not so much of the kind of travel nursing sort of concept and
right.
everything. Maybe this is them coming out of, the growth that was necessary during COVID and things like that. Like it sounds like they are in that transformational space.
Yeah, right. Yeah, I mean, you can't have too high a percentage of travel nurses and make it work. Really.
Yeah.
Okay, and then getting away from the systems to more the telehealth kind of platforms. Hims and Hers is expanding and betting on lab testing to sort of accelerate their growth. And so I've been watching Hims and Hers along with others really begin to sort of build a nationwide health brand for end consumers.
Mhm.
I'm watching this, but you and I were talking before. This is not necessarily lab tests related to a diagnosis. It's more that proactive, preventative. Let me run sort of the function like very large testing ahead of like some actual symptoms appearing. What are your thoughts about this?
I'm all for prevention, but again, as we discussed with function, making sure that they're connected back to a team that can help them interpret, understand the false positives, false negatives, and make sure they're connected ongoing so that it's not just labs and biomarkers that allow us to diagnose a lot of times. So are they connected to care teams to actually meet real diagnostic criteria, I think is a question I would have. So how is Hims and Hers really supporting these patients beyond just the lab test? It's exciting that they're offering this, but it needs to be part of a more robust spectrum of services.
Yeah, I mean, I think where it could get interesting is there's a partnership with Quest Diagnostics to execute this. So they would send you to Quest to get the blood drawn.
Yeah.
Quest does lots of things. And so that relationship could then also be in place for diagnostic screenings over time, but that's not where it's starting right now.
No. And then again, who's going to be that patient's partner for the interpretation of all of this new data? It's important that we have access to this, but again, the empowerment after the access to just the initial lab test. And how patients can then address issues as they come up. It's not that we shouldn't be doing that testing, but it needs to be part of a larger plan.
Okay, then in Fierce Health, Pyx Health, I guess is how you say it.
Pyx, I guess. Yeah.
Pyx Health rolled out AI-powered navigator for social needs among, sort of in and around all of these issues, Medicaid issues. You read it ahead, I think. What did you think about this story?
Yeah, I mean, this is exciting. I mean, this is a difficult space for a lot of care teams because we don't necessarily have the full social work or community health worker staff at times to really make sure we're directing patients to different services around their transportation, their housing, their food insecurity, and the like. So I think making this more accessible through an AI solution is always positive. I'm wondering how they're differentiating themselves, though. There's other databases that bring this information together. So having an AI chatbot on top of that is great, but is that the only differentiating piece? I'm not sure. But I think this is a great solution for a lot of, again, from my PCP standpoint, a lot of providers to partner with their patient on to make sure that they're using the right services.
Yeah, and the PCP should be their first place where they call or talk to about, gosh, how do I meet these work requirements? I have a job. Where do I send my information? So, I mean, part of this is that they're going to sort of have a technology tool that the doc can point people to, saying this will help you sort of meet those, because each state probably is a little different, et cetera. It's hard to navigate. Okay, and then Millie introduced an AI solution for maternity care. So Millie is a women's health clinic, and they are bringing this AI agent sort of focused on maternity care. Interesting. What are your thoughts about it?
I've been watching Millie. I know the CEO. She and I talk news, and I'm excited for this. I think a lot of women need this sort of support. I think it's very difficult in the typical kind of prenatal space to get your questions answered, to be able to really feel supported. So I think this is going to be strong. Again, hopefully this can be accessible more broadly and not just for those boutique type OB practices that are opening up, and who can afford the solution? Is there a direct patient access? Particularly when we're thinking about the inequities in maternity care. If it's only available for certain patient populations, they were probably a lot more likely to get this sort of support anyway. So how do we get this more broadly? But I'm excited for this type of solution, and I'm really proud of Anu here.
Yeah, and I think that's going to be a way that we judge them over time. But the AI tool certainly is at a cost point that you could offer it to every population, and we just need to see them execute on that. But yes, a lot easier than sort of in-person explaining everything, which is hard to scale. Okay, moving into the pharmaceuticals, Roche had a really good result in a breast cancer trial, and their stock's done really well. Have you followed this story? I can't pronounce it. Gudricent?
Yeah, exactly. Something close to that. Exactly. This is exciting. I mean, the estrogen sensitive breast cancer.
That's a significant. It says up to 70%. It's a lot of breast cancer is tied to that.
Now, this is huge. Yeah, I don't know what else to say. It's huge. Again, I'm always thinking access issues. Like, is this going to get to the people that need it? But yeah, this is exciting and a big deal.
There's a lot of women that need a better treatment than exists today. So, yes.
Can't wait to see kind of who's involved, what the demographics of that. What did they say? 4,100? Yeah, 4,100 patients involved. Like, what's the characteristics of that patient population that was tested on?
Yeah, they didn't give
I
a
would
lot
hope
of
it's got a
details
diverse
about that.
population, but yeah.
Right. Okay, and then Merck bought Cidara
Mhm.
after J&J sort of let it go. So it's an interesting sort of trade. It's a flu antiviral, influenza antiviral. I don't know much about it, but it was interesting that one huge company decided not to follow up, and then Merck picked it up for
Mhm.
9 billion. So clearly it has
Yeah.
some efficacy.
I have no idea what happened with J&J last year. This is exciting. I mean, I had to read a little bit about this as well too, but just how this can be used as a counter to, I hate to say this, that kind of anti-vaccination sort of conversations going around. It's meant to be more of a, they call it even in the article, a prophylactic. So it's actually editing the virus itself as opposed to preventing transmission of the virus, which of course has public health concerns because, part of our desire is to prevent flu from being transmitted as opposed to treating it directly when someone gets it. But this is an exciting additional option to have as part of our tool belt. So,
Yeah.
hopefully
Yeah, it's
Mark
not the
really gets
first
this out.
line, obviously,
Yeah.
but once I have the flu,
Yeah.
there hasn't been a lot of solutions. So adding
That's
this
exactly it.
is a great option. Yeah.
That's exactly it. That's exactly it. So yeah, I wonder what
Um,
happened with J&J last year.
yeah, I don't know. And then they bought
Halda. Yeah.
Halda
Yeah.
Therapeutics. Do you know this technology? You seen this?
I do. I read a little bit in more detail, but it's exciting. It's going to go across multiple different solid tumors, starting with prostate cancer. This came out of the Yale Ventures team. I don't know if you're familiar with them.
No, I don't know that.
Yale University has really leaned into the innovation space and has their own ventures studio, and Halda spun out of that. So this is exciting. This is totally novel technology, and it can go very far beyond just this initial use. So
Yeah.
I'm excited for it,
Yeah,
and I'm
but I
excited
mean,
that Yale developed it because that group is really strong.
yeah. Yeah, and we're sort of attacking cancer from all sides. We have been for years, but it feels like we're getting some momentum now
Hmm.
in lots of different therapeutics, different ways to approach it. And then Novo Nordisk cut their prices for the obesity drugs, Wegovy and Ozempic, and so they continue to try to compete in this space. They're going to be part of the Trump administration's sort of approach to reducing prices in return for getting weight loss to be covered by Medicare. But in conjunction with that, they're reducing prices overall. So
Yeah,
I think positive. Yeah.
this is very positive. I mean, these drugs are an unbelievable option for so many patients. It's more than just the elective sort of obesity piece. There's obviously a lot more evidence coming out in different, ways that these drugs are helping. So the more that they can become available more broadly and outside of, I think what kind of got me excited here was that they are purposefully seeking to offer these discounts outside of the arrangement with the Trump administration. So we're removing kind of that political slant.
Yeah.
I think that could help them, especially because, there is a lot more evidence around the tirzepatides, right? The Eli Lilly. So Novo Nordisk doing this first. I think they're trying to
Yeah.
step out in front.
Right.
This was pretty positive. I had not heard this. This is exciting.
Yeah. Yeah. And I think there's so many things that are sort of intertwined with weight gain, obesity, weight loss that I think a lot of people can benefit from this.
Yeah.
From this
Well,
treatment.
I mean, it's more than that, right? Even without the weight loss, it's impacts on chronic pain, addiction, dementia.
I hadn't
Liver.
heard the dementia
Oh
piece. That's
yeah, yeah.
interesting.
There was a study, I believe it was a VA study, but yeah, there's impacts more broadly than the
Yeah.
metabolic sort of space, which is the cardiology,
Yeah.
kidney,
Yeah. But I
liver.
have seen in alcohol, drug
Hmm.
addiction, I mean, all kinds of things. It really is
Yeah,
helpful for that.
yeah, very much so.
Okay, so then in the Health and Us, this was a story in the New York Times. It's an opinion story. I want to be clear about that.
Mhm.
And it's from the CEO of Patreon. His name's
Yeah.
Jack Conte. And basically, it's a really good video that I recommend people watch. It's entertaining, but it has the message is that social media algorithms, have have rotted our brain, is what he says. I mean, people call it brain rot because it's sort of mindless. And it's designed to keep you engaged and attentive to your device and not engage in the rest of the world. And I think there's no question that there's been lots of studies that's true. Where we have been stuck is, well, then what should we do differently? And so he is proposing that we kind of, it's self fulfilling, because Patreon's business model is to help creators monetize their work, help artists, help other songwriters, bands, anyone who's doing creative work. It's more of a tipping or subscription. I want to subscribe to this artist who's doing paintings because I love what she's doing and I want to support that work. And so he's sort of saying we should use the Patreon model of connecting fans to great artists across the whole internet. That's obviously self-serving to Patreon, but I thought it was an interesting point because we need something better. So I don't know. What were your thoughts about this?
Yeah, I mean, there's other examples of this besides the one I won't mention. I just realized Substack is in the same sort of space, right? And I'm subscribing to a handful of and paying beyond the free option on Substack, and trying to like promote independent journalism from that sort of direction. I mean, I think it's a necessary conversation that needs to be added to this larger algorithmic sort of focus that we have elsewhere. I think there's a larger community population that wants to be more in this sort of space, as we're seeing with these other websites. So I like this. It made me, it had like the feel good sort of primary care tint to it as well too. We should be caring for each other. Like it felt good. But
because he's creative himself. He made the video entertaining, even though it's not, it wouldn't have been super visually stimulating unless Jack Ante is really creative, which he is. So it gets a good point, but he promotes it in a way that's fun to watch too, kind of. So I'd recommend people check it out. Okay, moving into the AI roundup. We don't have any Web3 stories this week. We'll get back to that next week, but we will run through several AI stories. So Sanford Health, you had to help me find where they are. Embarrassingly, I didn't know where Sanford Health was, but they're in the Dakotas. Decent sized health system there. Yeah. They're embedding AI into their electronic health record to really help physicians, take all of this data and get actionable insights is the tagline. They talked about a kidney disease example as well as colon cancer screening. But what were your thoughts about this?
I mean, this is the direction we're going. There's other solutions coming up that are embedding in some of the larger EHRs as well. We need to get beyond just data visualization and need to support care team members, everyone, health plans, community health workers, and everyone, to actually do this sort of care and interpreting the data. So as it says, making it more actionable. I mean, this is where EHRs need to be leaning. So it's exciting that they have these two new solutions. The colon cancer screening piece sounds like they're really building something a bit unique there. I'd love to dig into that more around how they're visualizing that. Yeah, from a chronic kidney disease standpoint, way underdiagnosed, especially in the primary care space. So that's exciting. I think they're leaning into two areas that are critical.
Yeah, that's right. And both are. You can make a pretty big impact on people's health and quality of life in chronic kidney disease and colon cancer screening by, I would say following evidence-based medicine, but at scale, that's really hard to do in a practice of any size. So having tools that sort of bring things to the surface and ask a clinician to look at this potentially actionable insight could be really helpful.
That's exactly it.
Okay, and then Nvidia had their earnings last night. You'll be hearing this on Saturday, so it's a few days ago. But they beat earnings dramatically, and they continue to sort of grow, to the sky. $57 billion in the last quarter, and that was a huge uptick from the $47 billion one quarter ago. So that they continue to grow incredibly fast. There is this systematic issue of sort of all of the intertwining of, Nvidia is investing in companies, and then those same companies buy their chips. We'll have a story about that in a minute. But people were very concerned about, is the AI in a bubble? And this made people feel happy, at least for today. It's the next day after it. But I think positive overall for the stock market and for kind of the AI boom or whatever.
Yeah.
What are your thoughts about this?
That's the sum of it. It's a little bit more reassuring, but we'll see. We'll see how long that lasts.
Yeah. And then sort of on that line, there's lots of stories we could point to. We've covered them from time to time. Nvidia and Microsoft are investing $15 billion into Anthropic. They of course have Claude, which is probably the best for enterprise and best for software engineering. We were talking before the show about this capital flows diagram that if you're watching, you can see. It's very intertwined, where Nvidia is sort of at the center of this ecosystem. They're investing in lots of companies. The current story is Anthropic, but then Anthropic turns around and buys from Nvidia, and Microsoft's invested in Anthropic. That's where they use the cloud for a lot of their work. So it's all intertwined. My thought process is, I don't know that it's necessarily a problem, but anytime this super complicated capital flow has occurred, it typically doesn't end smoothly. I don't know where there'll be a problem, but it makes things more fragile in general.
Yeah, I love risky circular financing. It even says, this makes me nervous. I have no background in this, but just seeing this makes me nervous. You used incestuous before.
That's right.
Like that just, I feel like this could be problematic in the future.
Yeah, that's right. I mean, the music will stop. Every new technology, like AI, I mean, there's incredible capabilities, and it is going to be very impactful in how we live our lives. And at the same time, human nature is to sort of overemphasize kind of the impact in the near term and underemphasize in a 10, 20-year view. And so there's a decent chance that the financial markets, the stock market, will get like over its skis, get overly enthusiastic, and then somewhere AI will not perform. And maybe it's not this quarter, it might be next quarter, it could be a year from now. When the music stops, I mean, some of these companies will do well, but there might be ones that don't do that well too.
Yeah.
Okay, and then OpenAI and Intuit, the maker of TurboTax and QuickBooks, struck a partnership. And you and I were talking before, of course, Intuit, like all these software companies, is using large language models, including OpenAI's internally, to sort of help them run their software business. But the partnership is really not about that. The partnership is about OpenAI putting into its technology their solutions right into the OpenAI interface. So you don't have to leave your conversation with ChatGPT to be able to file your taxes. You can just do it right there with the chatbot. What are your thoughts about this?
I mean, to make the tax process easier, great. I don't know. I don't know why this makes me nervous. I don't know why enough about.
Well, I'll tell you why it makes me nervous. And so, I mean, I understand why Intuit's doing it. There are 500 million monthly users. Now that's globally, I think, but maybe it's 800 million. There's a lot of users every month that are in OpenAI's interface. And all the US citizens need to file taxes. And all of the small businesses need to use QuickBooks or something else to keep up with their financials. It will sell more product for Intuit, I think.
Yes,
there's no question about that. Why it makes me nervous is that, and I think I've been clear on the show, I'm not very trustful that OpenAI will use my data or anyone else's data for purposes that are good for me. I think they'll more likely use it to make money for OpenAI shareholders, because that's what they're required to do.
Yep.
And in order to file your taxes, you have to give not only your earnings, but your social security number, where your address is, like everything about your financial life, including your personal, highly confidential numbers like social security must be entered in. And the fact that I would use ChatGPT to take care of all that information and then expect that it will be placed in the right TurboTax cells and then deleted, I think it's just not realistic. I think that it's not going to happen. There'll be lots of information that then OpenAI is ingesting, and it may not be as clear how they monetize it, but they might come back to me and sell me something because they know I need it, or they know I've paid for it in the past for taxes. So anyway, that's what makes me nervous about it. But it isn't. I feel like the horse has already left the barn with that. I mean, I'm trying to get health records encrypted and held by individuals, not held by the large language models. That's hard enough. But financial records also, if I was in finance, I'd be trying to fight for that. So I don't know. That's what makes me nervous about it, but I can't stop it. It's not going to stop it. They have everything.
I'm the type that doesn't even like to use, like, how you can sign in with your Google ID to multiple different websites for purchasing everything. I don't. I create new IDs for every. I don't want all my data connected like that for the exact reason. So yeah, that's I don't think I'd be entering my tax info into ChatGPT for exactly that reason.
Yeah, and TurboTax has a great interface on its own.
Yeah.
I have an 18-year-old son who needed to file his taxes. We sat down and did it. And, it took maybe 15 minutes. It didn't take long at all. It's a great product. It's plenty easy enough through their interface, but people are going to use it through chat, I'm sure.
Exactly.
Okay, and the last story, Google released their new version of their model, Gemini, yesterday, Wednesday. So a few days ago, when you're listening to this, Gemini 3 Pro, and it immediately is the highest performing model. It's also the most expensive model. And then you pointed out that it has some other aspects that are, I don't know, concerning or need to be accounted for. So what are your thoughts about Gemini?
We are going to continue to see just more advancements on, the speed with which these different tools advance is just astonishing to me. So I'm excited that Google is giving OpenAI its run for its money. I think the point that I raised that you have highlighted here was just this initial hallucination rate. And so, of course, from a clinical standpoint, that definitely makes me a little nervous. But I'm loving how the speed, the ability for these to just advance here. It talks about being natively multimodal as well too, how it processes multiple different inputs together as opposed to relying on separate models. Like that's just exciting.
I mean, the demos, there's always a ton of demos. The demo that I was most surprised about maybe is that they had this demo of like a lecture, like a college lecture.
Yes.
And it's a video of it, and then Gemini can make flashcards for the student to study based on watching the video. And I had not seen video as an input before, but that's pretty useful because in sports or in education or in healthcare, a lot of stuff is a combination of, yes, there are words and text, but there's also physical movements and activities, and sort of context matters. So multimodal, I think, is an interesting benefit. I agree with you. I think I've been playing with it, but it's only been 24 hours. It seems really strong, but just the competition of all of these models kind of leapfrogging each other lifts everything up, and it delivers a better product in the long run. So great. Well, Kam, thanks for doing this. That's the end of the show. I really appreciate you filling in. You're have a very different point of view than Marcus, much stronger on the public health and actually science side of things than Marcus or I. So
Oh, no,
great to have your input.
This is fun. I love you guys' conversation every week. So adding my little slant, I'm usually on a treadmill yelling at one of you while I'm listening.
Right.
No, you forgot this point. What about the public health concerns? So I'm glad I can actually speak to it this time.
Yeah. Excellent. Well, thank you for doing this. We're excited to hear about your new adventure. When you're ready to tell us about it, we'll have to have you come back on to talk about your new idea.
I'd love to, actually. Yes.
Yeah. Okay. Thanks, Kam. Really appreciate you doing this.
Thank you, Vic. This is great.